A quick review: the pharmacology of the anti-diabetic drugs. The hyperglycemia, or the increased blood glucose level, is related to different factors. We're starting with if we have a dysfunction in the neurotransmitter in the CNS, if we have an increase in the renal glucose reabsorption, if we have an increase in the hepatic glucose output, if we have an increase in lipolysis, and if we have an increase in the glucose absorption from the GI tract. In the pancreas, we have alpha cells which will be secreting the glucagon. So if we have an increase in glucagon secretion, we have beta cells in the pancreas also. These are secreting insulin. So here, if we have a decrease in insulin secretion, will be leading to hyperglycemia. And the last factor, that if we have a decrease in the peripheral glucose uptake. So we have here I am mentioning two factors, that if we have a decreasing in the insulin secretion and decreasing in the peripheral glucose uptake, will be leading to hyperglycemia. And the other factors that I mentioned, all of them will be leading to an increase in the glucose level and leading to hyperglycemia. So depending upon the diagrams that we have seen in the previous slide, it will be now logic to predict the drugs that we are going to use in the management of diabetes. Now, the first one, it is insulin. For sure that whenever we have a destruction of the beta cell in the pancreas and we don't have an insulin. And the insulin, we have a different preparation for it depending upon the onset of action and the duration of action. So we have rapid acting, we have regular, intermediate, long acting, and ultra long acting. Beside that, we have one preparation to be given as an inhalation just before the meals. The other medications we are going to use, that for an example, we are using a drug that will be increasing the insulin production from the pancreatic beta cells, and I just put some of them, how it will be ending or how it will be starting, the name of them, so it will be easy to identify them. We have also the drugs that will be decreasing the glucose absorption from the small intestine, and the drugs that will be improving how the body is going to use insulin. And also we have the drugs that will be decreasing the glucose production by the liver and will be improving the insulin resistance due to the receptor insensitivity. And also we have the drugs that will be increasing the insulin production or will be increasing the concentration of insulin in the blood, and also will be reducing the glucose production from the liver. And also we have the drugs that will be block the reabsorption of glucose from the kidneys. That's the one we call it sodium glucose cotransporter 2 inhibitors. And finally, we have that analog for the that specific peptides that will be produced from the beta cells. And the one we call it the normal peptide, we call it an amylin. And this will be an analog for it, bramlinitide. Let me start this lecture by trying to explain the mechanism of action of insulin in a simple manner. So here we have the cell membrane. In the cell membrane, we have the insulin receptors, which compose of an alpha subunit, which located outside of the cell membrane. It's being connected with a disulfide bond to the beta subunit, which trans through the membrane. Part of the beta subunit, it is a tyrosine kinase enzyme. Now, this one molecules which compose of an alpha and beta joining with a disulfide bond to another molecules composing again from the same alpha and beta subunits. So now that's homodimers will be producing now the insulin receptors. Whenever insulin will be binding to these receptors, will be binding to the alpha subunit in this homodimer, will be activating the tyrosine kinase enzyme, and that will be produce an autophosphorylation for the tyrosine amino acids that part of these beta subunits. Whenever we activating phosphorylating the beta subunit, the tyrosine residues in the beta subunits, that will be leading to an activating of a specific protein inside the cytoplasm. That's we call it insulin receptor substrate. And that's protein, whenever it will be phosphorylated, it will be activated through different steps now will be leading to an activating a specific kinase. One of them, it is a phosphatidyl inositol 3 kinase. Now, this enzyme, through different steps again, will be leading to activate the endosomes, which inside the cells and carrying the glucose transporter type 4. So we'll be enabling now these endosomes to translocate and go to fuse with the cell membrane and to incorporate the glucose transporter type 4. Now, whenever we are incorporating the glucose transporter type 4 is going to allow now the glucose to enter inside the cells and then to produce a different effect. One of the tissues that will be depending upon the insulin to transport the glucose through glucose transporter type 4, we have the adipose tissue and we have the skeletal muscles and the heart muscles. The most important factors that will be leading to hyperglycemia is the decrease in the secretion of insulin from the beta cells in the pancreas. So in the management of hyperglycemia or diabetes, we are going to use the first group of a drug. It will be the insulin. So here I am going to talk about the insulin preparation. According to their duration of action, we have a different types. We're starting with those who has a short acting insulin preparations. Usually, if you look about them, you will find that they have a clear solutions at neutral pH. The first one will be the regular insulin. Now, all these insulin will be giving a subcutaneous injection. The regular insulin is about like 45 minutes before the meal and will have a duration for about 8 hours. And this regular insulin, beside another one, I am going to mention it, that's the one we give it as an IV infusion also whenever we have an emergency situation. Now, the other compound, which is very similar to the regular insulin, but it is having a faster onset of action, usually within 15 minutes before the meal it's supposed to be given, and usually have a shorter duration of action, about like 4 hours. Those are one we call it rapidly acting insulin analogs. So here we have insulin Lisibro. I'm going just to show you for everyone the structure of that insulin. Insulin aspart, and this also can be given an IV, and insulin glulicine. Now all of these insulin, as I mentioned, will be given by subcutaneous injection. Here you can see the normal structure for the insulin, which compose of alpha chain, which containing 21 amino acid, and the beta chain, which consists of 30 amino acid. And as you already know, we start counting the amino acid from the amino terminal. Now, in the beta chain, you can see that 28 and 29 amino acid, that if we just like flip it, just change the sequence of these amino acid, we are going to produce now the insulin Lispro. The other one, if you can see on beta chain, the amino acid proline number 28, if we replace it with aspartic acid, then we are producing the insulin aspart. Now here again you can see the normal insulin, that if we replace the amino acid 29 in the beta chain by glutamic acid, and we replace the amino acid number 3 in the beta chain with lysine, then we are getting the insulin glulicine. The other types of insulin preparation, we have the long-acting insulin preparation, but first we have the one we consider it as intermediate, the NPH insulin, or the isophane insulin will be working for about like 15 hours. Neutral protamine hagidorn. The real long-acting insulin preparation, the insulin Clargine, it is a peakless one given once per day because it's effective going up to 24 hours. It should not be mixed with any other types of insulin. And the insulin Ditimir for about like working for about like 17 hours. And the insulin Digludig will be working for more than 40 hours. Again, here the human insulin. If we replacing the amino acid number 21 in alpha chain with glycine, and we adding to the beta chain 2 arginine, then we are producing the insulin Clargine. And now you can see by attaching to the beta chain in the amino acid number 29, if we attach a 14 carbon fatty acid, that will be leading to insulin Ditimir. Also, if we are attaching to the beta chain through the amino acid 29 by a linker glutamic acid, we're attaching a specific acid here. You can see it that we are producing insulin Degludec. And here just to show you the different way of administering insulin by injection or by through a pump or by inhalation. However, the most common method of administering insulin, it is through an injection. And here the most appropriate site in the body to give insulin through an injection. And now I want to talk about the side effects for the administration of insulin. The side effect, initially the patient might be having some increase in his body weight because now the cells start to take the glucose and utilize it. Might be having some rashes, some swelling, specifically if he injecting the insulin in the same area several times. And he might be have some anxiety or depression. If he using the inhaled preparation, he might be have cough. However, usually these side effects, it will be resolved with continuation of the treatment normally. However, the most serious side effects and the most annoying one is hypoglycemia. Hypoglycemia, the patient will have different types of symptoms and signs. Probably the most notable one, it will be the sweating, it will be the dizziness, hunger, impaired vision, and also the fast heartbeat. So he have tachycardia. Now, if the patient having these symptoms of hypoglycemia, he is supposed to go with what we call it the rule of 15. So what is the rule of 15? He will consuming 15 gram of fast-acting sugar. It might be coming from one of these sources. He might be chewing 4 glucose tablets or drinking 4 ounces of fruit juice, or drink 4 ounces of regular diet, regular soda, not the diet one, okay, or he might be chewing 4 pieces of hard candy. Now, and he will wait now for 15 minutes and will check now the blood glucose. If it is okay, that's fine, then he will go and get his meal or his snack. If it is not, then he will be again consuming another 15 gram of the fast-acting sugars and so on. That's what we call it the rule of 15. The rule of will continue until now the blood glucose will be reaching 70 or above. Now, in the case of the patient, he is not responding, he is not responsive, he has some convulsive activity, or he is unable to ingest the sugar orally, then he must be administered the hormone, the glucagon. The glucagon can be administered in emergency situation as an injection or now also as a powder to be given through the nose.